ladies and gentlemen. Thank you as always for being here. This evening we are confirming that we have an additional 204 cases of Covid-19 diagnosed since yesterday, bringing the total to 1,329, reporting that there has been one additional death of a male in the East with an underlying condition, and extending mine and our condolences to the family and friends of the individual concerned. A breakdown of 965 cases available midnight the night before last shows that 55% of them are male with a median age of 45. 277 have been hospitalised. 36 of them were admitted to ICU. 247 or 26%, about 1 in 4, which has been the case all along, associated with healthcare workers. Dublin has the highest number of cases at 535, which represents 55% of the total. And in terms of transmission status, community transmission accounts for 47%. In terms of the global position, there have been 372,757 cases diagnosed with 16,231 deaths. And in Europe, in Italy, they have now reported 63,927 cases. In Spain, 33,089. In Germany, 29,212. In France, 19,856. And in the United Kingdom, 8,077. As you'll be aware, since we were with you last, we held a meeting of the National Public Health Emergency Team, which concluded this morning and made some decisions and provided some advice to government, and I'll just go through some of that briefly with you, if I may. So we recommended, firstly, that we adopt the WHO case definition as of the 23rd of March 2020, and to update our relevant guidance and algorithms and to publish these online, and that has happened. The HSE to put in place measures to increase our testing capacity in line with our updated case definition, and that is happening. That the NEFIT recommends self-isolation for all suspect and confirmed cases, including those who are awaiting a test or test result, and restriction of movement for their household contacts. And the HSE to revert to NEFIT with a description of the contact tracing process in use in line with current policy. In terms of our evaluation of the disease status, as we said we would do on a continuing basis, and as I indicated we would do at our NEFIT meeting today, we observed that on the basis that there were a number of confirmed cases now exceeding 1,000, an observed day-on-day increase in the number of admissions to ICU, the fact that there had been 6 deaths recorded at that point, and the fact that community transmission accounts for 45% of the cases, and that 25% of the cases were associated with healthcare workers. We made a number of recommendations to government recognising all of those facts and giving us a sense that whereas the public have worked very well with us, and as I've said to you last evening, a significant amount of compliance with which we're happy on the part of the public. Nevertheless, given the factors that we're observing in terms of the progression of the disease, it was our conclusion that further measures are necessary to strengthen the response that we have to the disease. And we recommended a number of different public health measures to government, which have been adopted. Firstly, that all theatres, clubs, gyms, leisure centres, hairdressers, betting shops, marts, markets, casinos, bingo halls, libraries and other similar outlets should close. That hotels would limit occupancy to essential, non-social and non-tourist reasons. That all non-essential retail outlets would close to members of the public, and all other retail outlets would implement physical distancing arrangements. That all cafes and restaurants would limit supply to takeaway food or delivery, and implement physical distancing measures in respect of queuing. That all sporting events to be cancelled, including those taking place behind closed doors. That all playgrounds and holiday or caravan parks would close. That all places of worship would restrict numbers entering at any one time to ensure adequate physical distancing. Significantly to raise the amount of money available on cashless card transactions. that all organised social indoor or outdoor events of any size would not take place, that social distancing, and as far as is practicable, would be ensured between clients and patients in confined settings such as long-term care facilities, either for the elderly or persons with special needs, psychiatric institutions, homeless shelters and prisons, that measures applicable to public transport, including cleaning schedules on public transport, to be improved, that people should not use public transport unless absolutely necessary, and that transport companies would apply social distancing measures and limit the numbers permitted on public transport at any one point in time, and that Gardaí would increase interventions where venues or outlets are not in compliance with or where groups of people are not adhering to recommended social distancing measures, that all household contacts of a suspect case, that is a person who is awaiting a test or test result, would restrict movements until the test is reported negative or for 14 days, whichever is the shorter, that individuals would work from home unless attendance in the workplace is absolutely essential, that social gatherings of individuals outdoors should be no more than 4 persons unless all those individuals are from the same household, that all non-essential indoor visits to other persons' homes should be avoided, that all crowded places, including public amenities, should be avoided, and that all cruise ship travel would cease. We intend to keep these measures under review and recommend that they are in place until Sunday, the 19th of April 2020, and we'll identify as we go along the response to the disease arising from some of these measures, the implementation of these measures in our ongoing evaluation as to whether additional measures are necessary. So we're happy to take any questions that you have in relation to any or all of that.
Tony, I just might focus first in terms of testing. So 17,992 tests carried out as of midnight last night. What's the current daily testing capacity in terms of how many tests are being processed every day? If
you don't mind, Killian DeGascon has joined us this evening to give us a little bit more detail as well as answers to that particular question. I might hand over to Killian if that's okay.
Okay, thanks. So at the National Virus Reference Laboratory, we're in the region of 1,300 tests per day at the moment. And then in the laboratories around the country, we're in the region of about 750 tests per day. Over the coming days, we expect that capacity to ramp up significantly, and we will get to the region of probably about 3,000 tests per day by next week, and that will continue to increase over the coming sort of 4 weeks, probably to a capacity of 15,000 to 16,000 tests per day. So I think it's been well documented that there have been sort of challenges in the context of global supply chains around lysis buffer and reagents for testing. And in addition, there has been, I suppose, significant demand for commercial kits. So the assays that we use to do the tests in the laboratories have also experienced supply chain shortages, because I guess that's always the problem when you're in the middle of a pandemic. Everybody is pulling on the same supply resource. But at this stage, as I said, we're seeing a significant increase in laboratory capacity, and that will continue over the next 3 to 4 weeks.
In terms of the average wait time, that was about a week, wasn't it? What is that at this point?
So I suppose there are kind of 3 questions in there. So I suppose maybe just to go through the process for people. So there's an initial consultation with the GP, which brings you into the system. So there's an electronic referral at that point. Then that refers you to a sampling centre. So there's up to 41 sampling centres in the community. So that's significantly increased capacity at that element. And then the sample itself comes to the laboratory for testing. So there's a number of steps through the process, and in the laboratory at this point where we're currently dealing with samples from the last sort of 24 to 48 hours. So at the laboratory side of things, we're working on samples that would have been taken at, say, on Sunday at this point. If we look at the last week, so the last time I would have been here, I talked about a turnaround time averaging about 10 to 12 hours, which would have been from the time the sample arrives at the laboratory to the time that the result is issued. And what we have seen over the last week, not surprisingly with the increase in demand, is that turnaround time has drifted out to about 26 hours from the time the sample arrives at the lab to the time the sample is issued. But again, it's just important to highlight that those will be samples from the community where people have been deemed to be well enough to self-isolate at home. And it is important to highlight that the message or the intervention, if you like, is about self-isolation. So the majority of hospital tests at this point are being performed at hospital. So for hospitalised patients are being performed on hospital sites. So their turnaround times would be significantly shorter than that.
Tony, can I just ask, just a lot of concern from healthcare professionals over the past 24 hours about protective gear and other issues. Have any of the patients, the 7 patients who have died so far, been healthcare workers?
We don't comment on the individual occupations or otherwise because of the low numbers as we do anything else, but regards to personal protective equipment, huge challenges for us and huge challenges globally. We know in New York and other places they're running low on stock, and we face equal challenges in a very competitive global market where there are export restrictions and where there's a great deal of volatility. That said, as we've said, we have secured a supply chain which is due to, we hope to begin arriving from China this coming Sunday, which will bring considerable stock of personal protective equipment, including protective masks, gowns and goggles. Our current stocks are certainly low, and we're in discussions with our hospitals, community, to make sure to reinforce the message as to how they should be used appropriately by those people who most need them in the most at-risk settings, particularly intensive care units and elsewhere, and also to remind people on the importance of not using them inappropriately because that will deplete our stocks. But we still have batches coming through until we reach that, hopefully that the first of many protected planes coming from China this coming Sunday. We're hoping that will start.
One more from me then. You've outlined how many healthcare workers have contracted coronavirus in terms of this at this point. Will you be telling us at any point how many of them were in intensive care units or requiring specialist care? Is that going to figure in?
The number of healthcare workers who are accounted for by hospitalizations, we have no plan to reveal that information at this point in time, Richard.
Killian, Shane Beattie from News Talk. It appears on social media we're at a stage now where people 10 days ago, 12 days ago, 9 days ago were displaying symptoms, looked for a test and still have not got the test and now no longer have symptoms. I'm just wondering, is there a point in those people still getting tested, and do they, if you have symptoms and then your symptoms go away, when you're tested, will COVID-19 show up in those tests?
It's a really good question. It really will depend on the individual. So what we know from the Chinese data set from about 72,000 individuals is that the genetic material of the virus is detectable for between 7 and 12 days typically after the onset of illness. We do know that if people have a more severe illness, that the virus is detectable for a longer period of time. So it will really depend on the individual as to whether the virus remains detectable at the point that they have their sample tested.
And what do people do if they've been self-isolating because they think they have COVID-19, waiting for a test, then don't get the test and get better, and then get a test and COVID-19 shows up? What do they do? People, because there's a lot of people out there now saying that, particularly around the weekend before St. Patrick's Day, they may have had symptoms which now have gone away, but they're still waiting for a test.
Yeah.
Well, the advice is to stay isolated for 14 days and to be 5 days symptom-free, and that test remains. And that's the most important advice we would give anybody in those circumstances, whether or not to have a test. And it's important to emphasise that the purpose of the test is to detect COVID, not necessarily for somebody's health reasons, because it makes no difference to the course of their illness. It's to improve our detection rate so we can instigate contact tracing. So the fact that they haven't got a test makes no difference to the course of their illness.
Would you accept that it's causing anxiety for some people that they're not getting a test, and that this becomes something that they're obsessed with, is getting a test to know do they have it or not?
I appreciate that, but I would reassure anybody who's listening tonight that just stick to that advice. Stay isolated for 14 days until you're 5 days symptom-free. The test will make no difference to the course of your illness. If you're feeling unwell, that's a separate matter. That means you have to seek help either through your general practitioner or otherwise. So don't let the absence of a test or the delay in getting a test lead to you seeking delay in seeking help, medical help, if that's what's needed. But for the vast majority of people, as you pointed out in your question, many of these flu-like illnesses, including COVID-19, are self-limiting and will disappear in a short period of time.
Just a final question, very briefly, Killian. In Italy, the head of the agency collating the figures says that the number of cases could be 10 times. The reality is the number of cases could be 10 times what the actual number is in Italy. So 64,000 earlier today, that could be 640,000. Is there a possibility that the number we're seeing today, that it's 10 times worse out there right now?
Is I suppose I can't sit here and say there's not a possibility, because that would be impossible to prove. But I think if you look at the positivity rate of the number of samples that we're testing, so we're in or around 6%. So that would suggest that a lot of the testing that we're doing is they could well be viral illnesses that are not linked to SARS-CoV-2 or COVID-19. So it's obviously possible that there's a greater burden of disease out there, but certainly the testing data that we have to date wouldn't really support that contention. But obviously that may change in the coming weeks.
Okay, thank you.
Just see here, one of your first recommendation there is a changed case definition. Patient with fever and another sign such as a cough. I think up to now it was fever or cough,
Yes.
new fever or cough.
Yes, yes.
Why so? And obviously this is going to make a change
Yes.
to the number of people who are referred for testing.
Yeah, so just to deal with that, so we spent quite a bit of time at our NEFID meeting having a discussion about this. What's clear is that the volume of people, the number of people, and I gave you an indication of that yesterday evening, who are seeking testing has been very large. A very significant increase in number of people coming forward since we changed the case definition to remove the country-specific component 10 days ago. Over the last 10 days, something in the order of about 20,000 or so people a day have sought testing. If we were to test at that regime, we would by a considerable distance become the number one country in the world for testing. And what that says to us, that a lot of the health-seeking behaviour coming forward and resulting in requests for testing are people who are not appropriate for testing. And we needed to think about focusing our case definition to identify people with a higher probability of having this particular infection. And so that's the particular reason for doing that, to bring a focus onto the testing and to ensure that we focus the testing more around cases that are more likely to be SARS-CoV-2. Bear in mind the point that Killian shared with you a moment ago, that even still with the significant increase in testing that we've had, which still brings us into line with the majority of countries in the world, are in fact one of the highest in Europe at the moment in terms of testing, of the numbers of tests that have been conducted, still only 6% of those are confirmed cases. So 94% of them are negative. And that has been a challenge to continue to reach all of the people who would seek a test and to get those tests to people in the timeframes that they would like. The important measure, as Dr. Henry has said, that we must emphasise, if people are waiting for a test, to assume that they have the disease, to self-isolate, and that their contacts restrict their movements. That's the essential public health action that would prevent transmission of this virus. That's underscored by the importance of other information that's become available to us that shows that the number of contacts being identified by the contact tracing teams per case has significantly reduced in the last week. It was in and around 20 a week ago, and now it's in and around 5. So in effect, the cases are giving rise to contacts among, by and large, their household contacts. And if we can ensure that people who have symptoms, as well as their household contacts, self-isolate, we can limit the transmission of this disease. That's the important measure. The test doesn't tell us anything further to give us good advice to those individuals. What we then want to do is to ensure that the testing is focused on the priority groups for testing. We will follow the ECDC advice in relation to that, in relation to hospitalisation, healthcare workers and so on. And as we go forward in the next number of weeks, we will grow the capacity to get us up to something in the region of 15,000 tests per day, which is not where we are at the moment, but that's where we want to go, because we want to continue to implement the policy the WHO has recommended using this case definition to test as many people as we can and to contact trace in respect of as many people as we can. We think that's the measure that's really critical in terms of controlling this particular disease. The advice of the WHO has been consistent in that regard. The social distancing measures that we've mandated are very important, but on their own they will not be enough if we don't contact trace and case identify to the maximum extent that we can. And while we have a challenge in testing every person who would seek to be tested at this moment in time, we think the right response for us now as a country is to try to focus that testing on those who are most likely to have the disease. That's the reason for the change in the case definition.
Presumably the WHO case definition hasn't changed. So does that mean we spread our net too widely when we introduced the change about 2 weeks ago?
In effect, we are having many more people than we need or that are necessary for testing or that are feasible or sustainable. As I said, if we were to test at that rate, 20,000 or so a day over the last 10 days, if we had done that level of testing, it would put us in a situation we were doing by far and away more testing than any other country in the world. We don't think it's necessary for the public health management. We don't think it's feasible. And we think that it's right for us to follow the WHO case definition now and to focus and target the testing. Dr. Henry, do you want
Just one of your colleagues, Paul, asked a question about people who might be concerned. It's worthwhile re-emphasising in case people don't understand this, that the test is of little or no value in people who are asymptomatic. It tells you nothing about what happens if you're negative and you become ill a few days later. But secondly, because it tests viral load in people who are asymptomatic, they don't produce as much viral load, and therefore the test is much less sensitive. So for people who are worried and trying to access a test to eliminate worry, it's really no use to you if you have no symptoms.
Yeah.
But I repeat my question. We cast our net too widely. In good faith,
In good faith, that's a fair conclusion, Paul. And as we've said in this all the way along, we won't say we'll get everything right all of the time. We did make a case definition. It was right for us to remove the country requirement because of the spread of infection across. We stayed with symptoms that in reality are common symptoms, like fever, like cough, and other URTI type symptoms. There was a very significant increase, probably well beyond the true prevalence of those symptoms in the population, in what we've seen coming forward for testing in the last 10 days, 20,000 or so per day, and that's our sense of it. It's way beyond the level of testing that we need to do for the public health management of this, and the right thing for us to do now is to focus our testing as we move forward on those highest priority groups and those who are most likely to have this particular infection. And we think that's the right strategy to continue to maximise the chance that we have of controlling the spread of this disease in the population. But I take the, and you'll be tired of listening to me saying this, I take the opportunity again to say that the key measure in terms of public health is for a person with symptoms and their household contacts to self-isolate and restrict their movements. That's the measure in the population that will interrupt transmission.
And just a question I asked last night for Killian, because you weren't here. What is the backlog for processing tests? And have there been cases where tests have expired because of delays involved and the sample is no longer?
So I'll take the second part of that first because it's easier. So no is the short answer. So the swabs that will be used for testing would have a shelf life in the range of 3 to 6 months typically. So there's been no problems with those. And then from a point of view of detecting virus, from the time the sample is taken, that's at least a week, probably more in many cases. So there's been no situations where there's been any expired swabs or anything like that at this point. And the first part of your question? Backlog. So again, there's a couple of different components to it. As I said earlier, there's the referral process, there's the sampling process, and then the laboratory testing process. And at the moment, I think it's fair to say that those don't all match, but the plan over the next 3 to 4 weeks is to ensure that the numbers coming in through the referral process will match the numbers being tested in the laboratory. So where the exact backlogs are at this point in time, I can't give you a definitive answer on that. We know from the laboratory perspective that we're currently testing samples from the 22nd and 23rd. So that's what we're seeing at the National Virus Reference Laboratory. So that's why I was saying to Richard earlier that the turnaround time has increased to about 26 hours from the time the sample arrives with us to the time that it leaves. I think the other thing, maybe just to add on the symptomatology, is that unfortunately with SARS-CoV-2, in contrast to say measles or chickenpox, there is no constellation of symptoms that is 100% sensitive or specific. So.
Good evening, Michelle Hennessy from the Journal.ie. If we just come back to the the testing numbers that you gave us tonight, the almost 18,000 it was, is this the number of tests that we have results for so far, or is this the number of people who have had swabs taken?
Yeah, really good question. So it's the number that has been resulted.
Okay.
Yeah.
So presumably the numbers who've had swabs taken is considerably higher than that?
So, but yeah, based on our experience, as I said, we have samples from the 23rd and we're just finished on the 22nd and the 23rd. So there would be a number of patients who have had their samples taken, but then have not yet been tested and have not received results.
Okay. And just to come back to the question that Shane asked there about the delay and people being tested after they stop being symptomatic. Obviously, I know, Colm, you said that it's not a factor in their illness, but presumably it is a factor in contact tracing if the person tests negative after they did have the virus, they potentially still could have passed it on to other people. So how does that impact on that process?
Well,
Well, so the process is still the same. Contacts are identified, and the clear advice that they're given is in relation to any symptoms that they might have at the earliest possible stage to report those symptoms, and they would be tested in those circumstances. And the key public health advice is still exactly the same as I've said. In respect of any contacts, particularly household contacts, close household contacts of a person who suspects that they may have this illness and who is awaiting a test, or where a test has been done and they're awaiting a result, is to assume that this is the disease and to self-isolate while they wait. And if we put that measure in place, we know now, because of the number of contacts per case we're seeing, in and around 5 per case that's identified, which is very encouraging in terms of the social distancing measures that have been in place now for 10 days and that we're strengthening. We think that that will be a really important way. We think that will feed through into interrupting the transmission of this virus. That's the key measure. So the test doesn't offer us any additional value in terms of that. If the individual complies with the advice that we're giving, if you have those symptoms, self-isolate for 14 days, and the contacts in your household, the people you live with, to also restrict their movements as though they were contacts of a confirmed case. That's the critical public health measure. That's the message we really want you to help us to try to get out. I should have said in respect of the question that I was answering for Paul, we had very good engagements with both the ICGP and the IMO today. We know we need to help the GPs with good quality, clear guidance and what we call algorithms, which are testing procedures to try to focus, if you like, the diagnosis of people with these common symptoms on the WHO case definition, so that we can target the testing to those individuals that we talk about, a smaller number of individuals who are more likely to have the disease. We think if we're successful in that the percentage that Killian gave you of 6% positivity will increase over the coming weeks.
Did you want to come in on that as well, Colin?
No, just to go back to that advice, it really is important. The test doesn't distract from the core message to act as if you have it, if you have those symptoms. And if you act as if you have it, you'll do the right thing in isolating yourself and your immediate family members. That's the core message.
I mean, I should point out that in many jurisdictions, it is policy to not test anybody in those circumstances. It is still our clear intention to test people in those circumstances. We have a challenge in doing it for all of the numbers that we have, but as we've said, we're trying to build our capacity so that we can do that in all circumstances. That's our policy intention. That's the advice of the WHO, but many countries, including in Europe, are not following that advice in the way that we are.
Just on healthcare workers, I know that you didn't want to comment on individual cases when it comes to the deaths, but I'm not sure if you're aware that there's a high-profile individual who online has been spreading information that one of the deaths in Ireland was a healthcare worker. So I just want to give you the opportunity, if that is the case, or if it's not the case, I mean, to clear that up and say that that is false information.
I don't know who that person is. I'm working on the assumption in your question that that's somebody not a part of the family of the individual. Is that correct?
No.
Well, that's a breach of privacy and confidentiality, and something that I think we could not criticise strongly enough.
But can I add to
privacy and the confidentiality of individuals, particularly at the time of bereavement, is paramount, and that's the kind of information that should not be spread by anybody on social media.
And I'd just like to add to that, and I know I've talked to some of you individually in this, the great majority of such rumours, that whether it was rumours of deaths among students in Cork or otherwise, are totally unfounded and have no basis, in fact, and serve only to create anxiety where there already is a great amount of anxiety among people out there in society. So commenting on this story one way or another would undo what I just said, but you can read what you want into what I'm saying now.
Last question for me then, also on healthcare workers. Obviously there's a high number in the numbers of healthcare workers who have it. Do you have any kind of a breakdown of whether they had close contact? Presumably a lot of them did, with confirmed cases, because there have been a lot of healthcare workers who are calling for the PPE for all of them to be used by all healthcare workers rather than people who are directly working with confirmed cases.
We have very specific advice, and we've worked very closely with the INMO and other organisations, and I had a very useful collaboration with Gabriel Collar and Martin Varley of the IHCA this week on this issue. We've been, as I said earlier, to the question, answer the question of one of your colleagues earlier, we are facing challenges in our stocks. We've secured a really good order, which is coming from China beginning next Sunday, hopefully. In the meantime, we want all our staff to be protected in the right circumstances when they're doing the right procedure. And we've issued very, very explicit and accurate advice to our staff on how they should protect themselves in all matters, not just with regard to personal protective hygiene, but in terms of their own distancing between people and their own behaviours in a hospital or a community setting. That's equally important here. And I'm not taking away from the importance of protective equipment. That's really important, and our staff need to feel supported. But they too have responsibility to adhere to those measures of distancing, of hygiene, as close as they can, particularly in view of where they're working and the risk of transmission. So to anybody who's worried, yes, we face challenges in our current stocks. We are maintaining stocks in all centres where it's needed, and we are trying to secure this large, steady supply which we've secured from China, which we hope will begin shipment in the coming week.
Thank you.
Just one fairly quick question. Last week you spoke about modelling that you'd been doing as regards where you figured the numbers of cases might go. You'd suggested on Sunday that could be as high as 355. It was following a fairly significant ramping up. We haven't reached that. You mentioned that, I'll phrase this wrong, sorry, because my brain's a bit melted, but I think you said it's now down from 20 people in close contacts or making 20 contacts, that's gone down to 5. So there are two reasonably positive bits of news, I would have thought. Now, given how significantly testing is going to ramp up, is there any succour to be taken from that, or is it just too early to say?
Look, it's better to see signs that like that than not. I think the encouraging one for me is the one that I mentioned around the 20 contacts dropping to 5. We want to see that that's maintained and maybe even reduced further if we can. We think that will reduce the reproductive number of the virus, the likelihood of transmission, and that's our objective in terms of protecting the population. In terms of the other, I think it's a little early to say. Obviously, it's better to see fewer cases than not. The projections, I think, when we shared them at the earlier part of the week, were very early. It's a very young model, so predicting reliably forward more than a number of days is difficult. But each day, as we add the new numbers of cases and other detail that we're getting now in relation to the cases, that model will get more stable. Its predictability and so on will be more robust, and we'll be in a position to make more projections as we go forward. So I think it'd be wrong for me to start to suggest that we think we're, because that number is lower than we might have projected, that we think at this early stage those measures are working. What we'll be doing over the course of the next week is ensuring that we monitor what happens, because the incubation period, as we know, of 14 days, we're at about a point now where we're about that point past the initial set of social distancing measures that we introduced. And we think if we're going to see an effect, it might be around in the course of the next week to 2 weeks. And we'll continue to observe that and to report on that. But I don't want to, let's say, overclaim in terms of what we're seeing at this early stage in the epidemic. The numbers are small, and it's too early for us to draw any kind of definitive conclusions. Thank you.
Let's ask a few figure-related questions. Last week, a figure of between 10 and 15,000 tests per day was put forward. At what point might we reach that? I mean, Killian, you said something like we might get to a point where we're doing 3,000 per day or processing 3,000 samples per day in our labs. I mean, what point will we get to tens of thousands or above 10,000 sort of figure?
So the plan at the moment is that will be in around 4 weeks' time, barring incident.
How many sampling centres are up and running at this point?
41 from
41.
none 2 weeks ago. Yeah.
And how many labs?
In addition to Killian's lab, we have, I think, 12 acute hospital sites and more labs coming on board. And
one of the public health laboratories as well.
Yeah.
Yeah.
Just a final one for me. Just in terms of the mortality rate in this country, it seems to be lower than many other Western countries. Is there any hypothesis for that at this point, or is it too early?
It's just too early to say.
I think it's too early. The median age of our cases is different to other countries as well, in the mid-40s. But the number of cases is small for us to calculate any reliable rates off a single. We're still in single figures. We'll keep watching that and reporting that and comparing it.
Can I ask you, in relation to the near 8,000 people who have been tested, how many of those, or a percentage of those, how many have received their results?
So the numbers that were given today, they have all received the results. The 17,009.
And in terms of the backlog or number of people who are waiting to be tested, what numbers are we talking about there?
So I personally don't have that number to hand. As I said, we're in the NBRL, we're probably a day to 2 days behind. So we're dealing with samples that were a day to 2 days old.
It had been about a figure of about 40,000 or so.
Sorry, so they're not.
A few days ago.
I guess, yeah, that's the terminology issue again, where people have been referred for sampling to have a specimen taken, but have not yet had that specimen taken. And then there's another cohort that maybe have been sampled, but have not yet received a result. So I don't have that breakdown.
There's no question, as we've said, Fergal, that the number of people seeking testing each day has exceeded our capacity to test. But we think many of the people seeking tests are people who don't need to seek tests and who don't fit the tighter case definition that we've now approved.
They're worried well.
Well, I wouldn't necessarily put it in that way. They may well be people who have other forms of viral illness that are much less likely to be SARS-CoV, that don't have some of the features that we think are important in this in terms of fever and cough. They might have simple things like runny noses and things of that nature. So
that'd be a role for GPs, though, wouldn't it? That GPs would take a particular focus on the algorithms and follow them through.
And they do, and so they did follow the algorithms. And obviously, there's been an understandable level of both anxiety and a desire on the part of people to get tested, and probably a desire on the part of many people to get a test almost as assurance that they don't have the disease when they're not well, when they're not unwell. Sorry, when they're unwell. I'm confusing myself.
Or an abundance of caution.
So people being very cautious, which is an understandable thing. People are concerned, people are worried. We monitor that through our market research information that we collect twice a week, and we see that people are more worried now than they were previously. It's understandable that people, when they have very mild symptoms, will come forward maybe at an earlier stage than they would, are more likely to present with very mild symptoms, or perhaps to seek the assurance of a test in a situation where they don't have any symptoms at all. And all of that has greatly exceeded our capacity to test and is not giving us any better information or ability to manage this disease. And so that's why we've tried to focus the test on a tighter case definition, if I can use that term, to work with the GPs, and we've communicated that out through the HPSC in the usual way to refine the algorithm that we're using and to continue to try to detect as many cases as we can and to contact those cases in line with the WHO advice. Thanks, Fergal.
Donald Trump said that you have to make sure that the cure isn't worse than the problem. Is anybody in your group or in wider government doing any modelling about this? Obviously, this is going to have a huge economic cost and so on.
So as part of the work we're doing on modelling, there are two components, and I think at a point maybe not too far into the future, we'll arrange for some of the team involved in the modelling work to come and present as part of our briefing here. But as part of this, there's a mathematical modelling which is about prediction and projecting forward numbers. There's also some modelling on the downstream impacts from an economic and social point of view as part of that work as well. So that's very much part of our consideration. We do want to understand not just qualitatively what we think the impacts of this might be, and we talk a lot in this forum about the impacts in the health service. We do want to try to understand what the impacts are on society in general, and some of that modelling work is focused on that. And I'd also point to the fact that we're beginning to do some work to try to stimulate research interest in SARS-CoV and in COVID-19, and all of the questions that arise in relation, which are not just laboratory and technical questions. We've spoken a little about the potential mental health impacts of some of the measures that are in place in society and other unintended consequences of long periods of time with the kinds of measures like this in place that we have. What impact might it have on things like substance misuse and consumption of alcohol, for example? What impact might it have on things like domestic violence and things of that nature? All of those things need to be part of our consideration and part of our alertness, if you like, to the unintended consequences of some of the measures that are in place, and to try to work to model that, to measure it, and to research it in a way to understand it better.
And finally, when you think about Italy, you remember 11 towns were locked down originally, and then you hear a lot about Bergamo and so on. I'm not getting a sense of any sort of regional play here. Will that come at a time where eventually you'll say, Monaghan or somewhere like that, is the disease is circulating there and you should be wary or something? Or will we get that sort of feel? Or basically we're just being considered as one entity, the Republic and maybe the island. But will that kind of regionality be evident as things move on?
And I think as we move on, our trending will become, let's say, as the number of cases grow, our ability to be able to interpret those regional variations will increase. If we see significant changes at a local level that merit more regionally based restrictions or measures or responses than we have in place at the country level overall, then we won't hesitate to respond to those. But at the moment, we haven't observed anything of that nature. Clearly, there are clusters in place in particular locations, and the response to those individual clusters has been part of our let's say national and local and regional response. But in terms of, let's say, societal level or community level responses of the kind that you've seen in Italy, we haven't identified the need for anything like that at this point in time here.
Sorry, Tony, excuse me, for those of us at the back of the class, would you explain as clearly as, would you explain as clearly as possible, language-wise, what changing the case definition today means? Because people might be wondering, what's the change about the symptoms? So what's the difference today or tomorrow as opposed to yesterday with this?
So a case definition is very important in the diagnosis of any infectious disease. You look at the various different symptoms that a person has, and I think we made clear in the early stages of this, we also looked at the history that people had in terms of where they had come from in the world when travel was an important part of this. And at a point in time, we dropped that travel requirement. And part of the challenge of this disease is that the symptom component of the disease relates essentially to pretty common symptoms that, as Killian said earlier on, they're vague, they're not very specific to this particular illness, they're common to lots of types of respiratory common cold type infections, whereas the travel part might not have been that common. So we moved from a situation where maybe not very many people met the case definition because they hadn't been, for example, to Asia, they hadn't been to Italy, to a situation when we removed that component, the travel component, we were essentially identifying people with what are common symptoms. And the experience we've seen over the last 10 days or so since we did that, combined with the extent of concern there is in the population, led to a very significant increase in the number of people coming forward looking for testing, far more than I think is either necessary as a result of the management of this disease or feasible or sustainable from our point of view in terms of testing. And it was right and proper that we look at that and seek to focus the testing more on a smaller number of symptoms that in particular include fever and some other symptoms like cough and respiratory symptoms, and we've set that out. And that will be a more focused case definition that GPs will work with to identify patients, and so perhaps then not every person with cold-like symptoms will in fact be recommended for testing because they don't have a fever.
Okay.
And so that's to focus things more on this particular disease.
I know you don't like individual cases and all of that, but Claire Byrne said last night that she has COVID-19. She didn't have a fever. So are we going to have people now who have COVID-19 who, because they don't have a fever and respiratory issue, who have COVID-19 but they're not going to be tested because they don't have both?
So it is possible, but the vast majority, one of the most common symptoms is fever. It's a very important part of this particular illness. That's why it's part of the WHO case definition. That's why we're using the WHO case definition. The advice for people with symptoms of these kinds of illnesses, whether they have fever or not, still remains the same. That if an individual has mild symptoms, they should self-isolate. They should take the measures we're recommending in terms of their family contacts and controls. So the measures will be exactly the same that we're recommending for them and what they should do. And we think that's the important step in terms of the interruption of transmission of this particular disease. Thanks, Shane.
Quick, I promise. Just two things. When the test is taken, how long until the sample expires? And the other thing is, I'm just wondering about the 6% you said, because the numbers today is 7.3% on confirmed cases with the 17,992 or 3, whatever it was. It's actually 7.3, I think. So it's just one was the 6% from a few days before, just I don't want to report it wrong, you know.
Okay, Killian?
So, excuse me, just on the first part, So the swabs themselves that we use would have a shelf life in the range of a number of months, so that's not a concern. From the point of view of after the sample has been taken, then in the swabs that we're currently using, there's a viral transport medium in there that sustains the virus in essence. So typically that gives us in the region of 7 to 10 days from the time the sample is taken to retrieve the virus. On the positivity rate, I think, so just looking at the numbers that, I suppose what we've seen in the NVRL over the last week, I suppose, has been a range of positivity rates anywhere between sort of 5 and 9%. The number over that, I suppose, we're trying to be consistent and looking at a particular time frame. So at the last week where we had a positivity rate of 6.4% was what we had at the NVRL over sort of the week, say, ending Sunday. So it's possible that between the additional days, sorry, I don't know if Rona wants to come in there.
So we always, on a Tuesday, we report all of the tests completed as of Monday evening. So so it's the number of positive results on a Monday as a component or as a fraction of the total tests done on a Monday. So if you include the additional cases done in the last 24 hours, it will go up
I figured
small.
as much,
So
but yeah. That's right. Thanks.
Okay, thank you very much.